So, welcome everyone. It's my great pleasure to introduce Dr. Tami Bang to our department. Really, I should say welcome back, because she was an undergraduate here at Yale and completed her degree in biomedical engineering with honors, of course. She went on to earn her medical degree in the University of Colorado, where she completed her residency and fellowship under the tutelage of Peter Sachs. After graduation, she joined the faculty at University of Colorado. Correct me if the details are off. For a while, and then you moved over to National Jewish Health, which is also in Denver, and it's a super subspecialized pulmonary institute. Is that accurate? Yes. Where a lot of what we know and how we diagnose and treat ILD comes from. So she's just this last year, she's been nominated for a teaching award and faculty of the year award, which is very easy to understand why, just having spent the morning with her in resident conference and in the reading room. So it's very easy to understand why she's known as an amazing educator and radiologist. Tami's clinical passion is ILD, which is not surprising given where she works, and pulmonary manifestations of autoimmune disorders. And we're really grateful to her and her group for moving forward the effort to understand the ILD better, the imaging of ILD better, and to be able to hopefully take better care of patients moving forward with ILD. The cardiothoracic imaging community as a whole is very lucky to have the leadership and dedication of Tami Bang. She's been involved in RSNA, ARRS, STR, NASCI, ACR, SAVI, and recently gave a talk at the Cardiothoracic Society of New York. So she's really an amazing, highly sought after speaker. I tried to listen to your talks at ARS, but I missed you. Finally, I'd like to note that Tami is an avid skier. And while I'm sure that we cannot wow you with our local mountains, I am soliciting an open invitation for the Baders to be both. That was shameless. Thank you. Thank you. All right, Tami Bang.
Oh, wow, thank you so much for the kind introduction. Thank you for the invitation. I'm so excited to be here. Thank you all for being here. This is actually just a wonderful opportunity to get to meet everybody. As was mentioned, I'm coming from National Jewish Health. It's a respiratory institute in Denver, Colorado. The residents have sort of heard this spiel before, but I feel very fortunate that I get to work at an institution that's staffed by a lot of incredibly skilled and expert pulmonologists, rheumatologists, ILD experts, allergy and immunology. And at National Jewish, a huge portion of what I do ends up being multidisciplinary conferences, a lot of consultation with other colleagues. And I thought today would be a really good opportunity to share some of the things that I've learned and I've gotten to, that I've learned from our, expert colleagues, as well as some of our multidisciplinary and collaborative efforts. So today, I'm going to be talking about a topic that's of actually great interest to me, which is immunodeficiencies, or specifically common variable immunodeficiency, and then the interstitial lung diseases that come along with it. So I'll start by saying I have nothing to disclose. And for our conversation today, we'll start by talking about common variable immunodeficiency, or CVID. We'll talk about some of the clinical features that we encounter, as well as some of the diagnostic features that we see. But then we'll really start focusing on the radiologic findings, specifically the thoracic radiology findings associated with CVID. We'll then start talking about interstitial lung disease, and specifically GLILD, which is granulomatous lymphocytic interstitial lung disease. It's a unique form of ILD that occurs in our patients with immunodeficiency, and specifically with our patients with CVID. And then we'll sort of take a step back and think about what role we play as radiologists as these patients are being diagnosed, evaluated, and surveilled through the course of their treatment. So common variable immunodeficiency, or CVID, is actually kind of a broad term that applies to a group of disorders. There are a number of variable clinical presentations and phenotypes that fall under the category of CVID. So as such, you can imagine CVID is actually one of the most common forms of immunodeficiency, just with its sort of broad definition and characterization. I'm not going to go into great detail about the diagnostic criteria because there are actually a couple of different diagnostic criteria that can be applied. Generally speaking, all of these patients have low serum immunoglobulin level and a poor or absent response to vaccine. So with those things in mind, you can imagine that nearly all of these patients are going to develop infections, recurrent infections, particularly pulmonary infections. So when we think about the infectious presentations of patients with CVID, I put an asterisk on here because they can have many different presentations. They can be acute infections, chronic infections, acute on chronic infections, recurrent infections. So these patients really have many different infectious manifestations. We oftentimes think of them as having respiratory infections, upper respiratory infections like sinusitis, but also lower respiratory infections like infectious pneumonia. But don't forget that these patients will have systemic manifestations. So conjunctivitis and skin infections are very common in this population. They're also prone to acute or chronic gastrointestinal infections. And also, infections that require more urgent action like septic arthritis or meningitis as well. I think what makes CVID really interesting is that they also get a lot of non-infectious manifestations. So this sort of falls into the terms of PID, primary immunodeficiency disorders, or what's also people are starting to use the word IEIs, inborn errors of immunity. And that sort of touches on the fact that these are not just immunodeficiency disorders, these are immune dysregulation disorders. So when these patients have CVID, it's not just immunodeficiency, they get dysregulated immune systems, which really manifests with a lot of autoimmune presentations. So autoimmune cytopenias like autoimmune hemolytic anemia, thrombocytopenia purpura, very common in this population. It's also very common to see things like enteropathy or chronic malabsorption. In my world, we see a lot of these patients because they get interstitial lung disease. And they can also get malignancies, particularly lymphomas or diseases on the lymphoproliferative spectrum. So the non-infectious manifestations of CVID are now coming to a lot more clinical attention, probably because we're getting better at treating the infectious manifestations, right? So as patients are identified, they are typically treated with immunoglobulin replacement therapy. It can be either intravenous or it can be subcutaneous, and also with identification of infections and prompt antibiotic treatment, we've seen improved survival and improved quality of life in our patients with CVID. Now that means that as we're seeing less morbidity and mortality from infectious standpoints, now we're seeing more morbidity and mortality from the non-infectious standpoint. So up to 70% of our patients with CVID will have some form of non-infectious or autoimmune disease, and the majority of them will also develop chronic lung disease to some extent. So that means that in a small portion of our patients, that chronic lung disease, whether it be interstitial lung disease or whether it be chronic airways disease, may be either a presenting sign or may present before the patient has a formal diagnosis of immunodeficiency. And those are the cases where I think we as radiologists can be really helpful if we identify that pattern or raise the possibility of immunodeficiency and maybe start the diagnostic work. So the chronic lung diseases associated with immunodeficiency generally fall into three categories: airways disease, malignancy, particularly lymphoma, and then interstitial lung disease. The thing to remember with our patients with immunodeficiency and chronic lung disease, incidence tends to increase with time. So more long-standing disease means a higher likelihood of having chronic lung disease. Generally speaking, chronic lung disease is associated with decreased survival. So obviously very important for us to recognize and hopefully result in intervention. And then finally, chronic lung diseases can develop or progress even while these patients are on immunoglobulin therapy. So again, another place where we are oftentimes being asked to evaluate these patients over the course of their disease. So why is it important that we know this? Well, as it turns out, CVID can actually be a challenging diagnosis to make. True story, one of my very good friends, who I've been skiing with for years, a couple of years ago was diagnosed with CVID. And at that point, she and I had been skiing together for, I think, 7 seasons, going on trips together. And I think every year she got one bad sinus infection or one bad bronchitis or something. And it would take her out for a week or 2, but then she'd go back to skiing, mountain biking, doing your typical Colorado activities, right? She's a very active, otherwise very healthy person. And 7 years after I knew her, she was diagnosed with CVID. And then she said, that's why I always get that really bad sinus infection every year. That's why I get, these bad pneumonias and stuff. So in the literature, they say the delay in diagnosis on average between the first episode of infection to eventual diagnosis and treatment is somewhere around 7.5 years. But chronic lung disease is very, very common in this population. So we as radiologists might be the first to raise the possibility of an immunodeficiency, right? So if we recognize patterns like bronchiectasis, interstitial lung disease, patterns that might suggest an immunodeficiency, we might be the first to sort of get the ball rolling on a diagnosis. And of course, we as radiologists are always looking for malignancies, things that might be subclinical, that might be not unknown to the patient or the provider. So let's start with the first broad category of chronic lung disease in our CVID patients, which is airways disease. So airways disease, I have to say, airways disease and CVID doesn't look a whole lot different than inflammatory airways disease and other processes. So of course, we're thinking about airway thickening, bronchiectasis, mucoid impaction, and of course, some of the things that go along with it, like tree and bud nodularity or mosaicism. So example here on the right is a patient with a history of CVID. I'll point out that there's some bronchial wall thickening here in the right lung base, but it's pretty asymmetric. If you take a look at the left lung base, there's a lot more bronchial wall thickening and also a lot of mucoid impaction. Another example here is a 34-year-old woman with CVID, also with chronic airways disease. I'll point out that she also has some areas of bronchial wall thickening, but I think on this, you can also see there are these geographic areas of low attenuation or mosaic attenuation. She went on to get expiratory images, which very nicely outline those areas of air trapping to go along with it. And on coronal imaging, you can see she's just starting to develop a little bit of bronchiectasis here in the left lung base. So on the topic of bronchiectasis, this is actually very common in our patients with immunodeficiency and of course with our patients in CVID. Up to, the literature is pretty variable, but up to 79% in the literature has been reported in patients developing bronchiectasis, and it's resulting from repeated infections. Tends to be basal predominant, but this is one of those cases where chronic lung disease incidence increases over time, right? So the more longstanding disease, more likely they are to have repeated infections, increases the likelihood of bronchiectasis. And we know from the Fleischner glossary that bronchiectasis is not considered reversible, right? It's irreversible dilatation of the airway. So we're not going to see it improve with therapy, but these patients are generally treated with supportive care like good airway clearance, prompt infection treatment or prevention. So example here of a 29-year-old man. This is a man who had a lot of episodes of pneumonia, and in this case has some pretty severe basal bronchiectasis. So we see a lot of airway dilatation, but also airway thickening and airway impaction. And then also, if you take a look right there, you can see some areas of mosaic attenuation. Unfortunately, this gentleman did not get expiratory images, but certainly has some mosaic attenuation related to his airways disease. All right, the second broad category of what I would say chronic lung disease is malignancy. Having said that, I'll say it's not malignancy limited to the lungs. You can get malignancy in other areas as well. And it's important to know that our patients with CVID, again, have immune dysregulation, and they have a higher rate of malignancy than the baseline population. We most commonly think of lymphomas, particularly non-Hodgkin's lymphoma, but these patients can also get gastric cancers and non-melanoma skin cancers as well. So in one large review, they had reviewed a large series of patients with CVID, and they found a 27% incidence of malignancy. So again, relatively high incidence of malignancy in this population, the majority of which are lymphomas. These also include the mucosa-associated lymphoid tissue or multiple lymphomas. An example here is on the right. This is a patient who presented with these findings. It's sort of a mass-like nodular opacity in the right lung base, very peribronchovascular with a sort of air bronchogram, and also with a little bit of satellite nodularity around it. Just in general, the forms of when these patients present, they can get pulmonary lymphomas, which are really characterized by nodules and sort of mass-like consolidations. This example was a patient who was being followed for chronic lung disease in CVID, but presented with increasing respiratory symptoms, weight loss, and was found to have multiple new and enlarging mass-like opacities throughout both lungs, and was ultimately diagnosed with B-cell lymphoma. All right, and then the last category of, or the third category, I should say, of chronic lung disease in these patients is interstitial lung disease. So interstitial lung disease constitutes a pretty large portion of the non-infectious complications in our patients. The literature is pretty variable, anywhere between 15 to 60% of patients are thought to develop interstitial lung disease at some point. Pathogenesis is really not very well understood. There have been some links to genetic components, some thoughts that it could be related to a specific exposure or potentially infectious causes. Again, T-cell dysfunction or immune dysregulation has also been thought to play a component. Having said that, there's no really good way of predicting who will develop interstitial lung disease versus who will not. But what we do know is that unfortunately, interstitial lung disease is associated with a poor prognosis. What makes this challenging is that it's actually a pretty diverse process. We can see a number of different patterns in our patients with CVID. We've seen patterns like nonspecific interstitial pneumonia or NSIP. Organized pneumonia is also a pattern that we've encountered. Very commonly, we can see lymphoid hyperplasia or granulomatous disease. And just to make things even more complicated, you can get overlap of these. So the entity known as GLILD, or granulomatous lymphocytic interstitial lung disease, is a combination of both granulomatous and lymphoid hyperplasia on pathology. So with this degree of diversity and heterogeneity in the appearances of these patients, this is where multidisciplinary discussion really plays a big role. It takes a lot of input from our pulmonologists, our allergists, and our immunologists, as well as radiology and pathology, to really evaluate these patients to come up with a diagnosis and a treatment. So just to highlight some of the different appearances that these patients can have, this is a 61-year-old man with a history of CVID. He was actually found to have lymphoid interstitial pneumonia on biopsy. He had no evidence of granulomatous disease. And on his CT, he has multi-station lymphadenopathy. So we see enlarged lymph nodes in both mediastinal and axillary distributions. He has pretty abnormal lung findings. He has these areas of kind of peribronchovascular nodularity and consolidation, also with some areas of septal thickening and more confluent ground glass. Another example here of a patient with a more organizing pneumonia pattern. This patient, also with CVID, has areas of peribronchovascular consolidation, and just a sort of a suggestion of a reverse halo sign in that right upper lobe, where we see kind of peripheral consolidation and some central clearing. And yet one more example of a patient with an NSIP pattern. Here in the lung bases, you can see a lot of ground glass and traction bronchiectasis, basal predominant, and a nice NSIP pattern here. But from here, we'll move on to granulomatous lymphocytic interstitial lung disease, or GLILD, which is, again, a form of interstitial lung disease that is uniquely related to immunodeficiency. It is considered a distinct form of ILD, so it's separate from other forms of lymphoid hyperplasia, and it's separate from things like NSIP or organizing pneumonia. It has a strong association with CVID. The epidemiology is not super well understood. There is a fair amount of heterogeneity, as you can imagine. A lot of these patients either don't go to biopsy. There's also a subset of these patients who are either subclinical or asymptomatic. So there's a thought that that these numbers might be an underestimation of the actual incidence that we see. It is unique to immunodeficiency disorders. I think we see it the most in CVID, which might actually be due to the fact that we see CVID as probably one of the most common forms, but you may encounter it in some of your other inborn errors of immunity. As the name implies, it has both granulomatous features as well as lymphoproliferative features, but has a variable clinical course. Some of them are going to progress. Some of them will be either asymptomatic or subclinical. But what we do know is that, unfortunately, GLILD is associated with poorer long-term outcomes. So just an example here on the right is a patient who does have a history of biopsy-proven GLILD. This patient also has these areas of kind of discrete peribronchiolar nodules, but also areas of ground glass to go along with it. So this is a relatively newer entity that's been defined. And so a consensus statement was actually put forth several years ago by a group of experts or a panel of experts with suggestions on how GLILD should be diagnosed. The good news for radiology is that chest CT is considered essential in the diagnostic workup. So we really have to have radiologic findings proving that there is an interstitial lung disease. Bronchoscopy is typically performed to exclude a potential infectious cause. But surgical lung biopsy may be necessary to make a definitive diagnosis. As we talked about, unfortunately, it's difficult to predict who's going to progress, who's going to be stable. It can have a very variable or fluctuating course of disease. So as a result, most of these patients are going to be followed over time with both clinical parameters, but also with imaging. Just a word on how this appears on pathology. It is an interstitial pneumonia. There are components of some component of lymphoid hyperplasia. So it can be forms of lymphocytic interstitial pneumonia, follicular bronchiolitis, or nodular lymphoid hyperplasia, as we see here. But they also must have granulomatous components, which are typically non-necrotizing granulomas, as we see here, kind of adjacent to the airway and the pulmonary artery. In terms of imaging, GLILD is a lower lung predominant process. So these patients will very classically get mixed nodules of either solid or ground glass appearance. They're typically lower lung predominant with a perilymphatic distribution. So we'll see them as peribronchovascular. You can see them subpleural. We can see some areas of septal thickening, as we have an example here. They can also get areas of fibrosis. So just examples of how this appears on a coronal imaging. On soft tissue windows, these patients almost always have lymphadenopathy, typically mediastinal, can be in other distributions as well, and they almost universally also have splenomegaly. So I realize it's a chest CT and we don't get to see the entire spleen, but you can probably imagine that the spleen is almost the same size as the liver. The expert panel in their consensus document didn't rank any features that were absolutely necessary or to make the diagnosis, or absence or presence of which would make the diagnosis. But these were all features that were suggestive of the diagnosis of GLILD. As you can imagine, I mentioned a bunch of things, nodules and ground glass and septal thickening, which are not particularly specific, right? We have a lot of overlap with these other processes. So again, these are cases in which multidisciplinary discussion and conferences really make a big difference in the workup of these patients. So just a couple of examples. Here's a 43-year-old woman who actually did have biopsy-proven GLILD. So here we are in sort of the mid-lungs. This patient has a lot of areas of subpleural ground glass and nodularity. We have some areas of more confluent ground glass as well. As we move more inferiorly, as this is a basal predominant process, we're seeing increasing parenchymal findings. Again, areas of some septal thickening and some areas of ground glass and nodularity. I think the coronal images very nicely show that this is a basal predominant process. And of course, this patient also has a very large spleen to go along with it. Here's a case that actually came across our institution a couple of months ago. This is a 43-year-old man who has CVID and suspected GLILD. I will tell you, this guy didn't actually go to biopsy, but had a working diagnosis of GLILD. And in his case, here in the upper lungs, we can see some of the findings that we've talked about, peribronchovascular nodules, a little bit of ground glass. But I'll point out, in his case, we're actually seeing some areas that look more like traction bronchiectasis, right? Here in the anterior left upper lobe, even some areas that look like honeycombing in the anterior right upper lobe. As we get to the lung bases, we see a lot more of these parenchymal findings, more ground glass, more nodules, but we're also seeing these areas that look like irregular traction bronchiectasis, right? So this is a case of somebody with GLILD who actually looks much more fibrotic, which we can see. We don't, unfortunately, I guess good for the patients, we don't see GLILD, or we don't see fibrosis in all GLILD cases, but it certainly is a feature that we can see. So again, basal predominant parenchymal process, both in terms of the ground glass, but also in terms of the fibrosis as well. So just to summarize, the imaging findings of GLILD, remember that it's a basal and lower lung predominant process. We are typically seeing things like nodules in consolidation, tends to be perilymphatic, peribronchovascular, and subpleural. We can oftentimes see interlobular subthickening, but most, if not, you can never say always, but nearly all cases are going to be associated with lymphadenopathy and splenomegaly, to the point where if you don't see splenomegaly, you might start thinking of another diagnosis. It can have fibrosis, not always present, but when it is there, it usually is associated with a worse prognosis. So what is important for us to remember? Up to 15% of these patients can be subclinical or asymptomatic, which means that we might be seeing these findings even if they're not associated with discrete or definite respiratory symptom. But we do know that GLILD itself is associated with lower survival and poorer long-term outcomes. And there's also been evidence to show that patients with GLILD actually require higher doses of immunoglobulin therapy to maintain their normal trough levels. So all of these to say that if you do identify this, this actually can make a difference in terms of how these patients are managed. It certainly can make a difference in terms of their overall prognosis as well. Just a word on management. There are no randomized control trials, so the data is somewhat limited. Generally speaking, these patients are of course managed according to their clinical symptoms. So patients who are minimally symptomatic or asymptomatic may not be treated initially and may be followed. Obviously, if they're having persistent or progressive respiratory symptoms or progressive abnormalities on CT, they will typically be treated. First line therapy starts with corticosteroids, but these can be switched to steroid-sparing agents, and there's some use of rituximab that has been used, but again, pretty limited data in terms of how long-term outcomes are. I get asked a lot about PET-CT and whether there's a role for PET-CT in the evaluation of these patients. And first thing I have to say is that there's very limited data. There's not a lot of information with this being a relatively rare disease and just not in existence for a very long time. We do know that GLILD is a metabolically active disorder. You can imagine, right? We know that granulomatous disease is going to be FDG avid, and so is lymphoproliferative disease. Progressive GLILD has been associated with higher SUV activity or FDG activity, but there's not a lot of specificity. There is significant overlap with lymphoma, and so you can imagine that having a PET-CT in the setting of GLILD versus PET-CT in the setting of lymphoma is not going to be particularly specific. There is some data that has shown declining FDG activity after treatment, so there may potentially be a role for PET-CT as these patients are surveilled before and after treatment, but the jury's still out in terms of the role of PET-CT in these patients. All right, so this is a question that we get asked a lot. There are a lot of overlapping imaging features between GLILD and other processes like sarcoidosis, lymphoma, organizing pneumonia. So how do we tell them apart? can we tell them apart? The truth is we can look to some signs that can point you in one direction or the other. Unfortunately, these are all cases where, again, you're probably going to need multidisciplinary discussion. And sometimes these patients will need to go on to biopsy to get a definitive answer. So how about the setting of somebody with peribronchovascular nodules and lymphadenopathy? Those are words that we use with GLILD, but we also very commonly use with sarcoidosis, right? In fact, I think a good number of our patients that we get referred come with the diagnosis of sarcoid because, you know, they went to biopsy and they found granulomas. And so the question is this sarcoidosis or is this GLILD? Well, to compare and contrast, GLILD tends to be a lower lung distribution. Sarcoidosis we know is typically upper or mid lung predominant. In GLILD, obviously both of them can have enlarged lymph nodes. In GLILD, the lymph nodes very rarely calcify, whereas calcifications are relatively common in sarcoidosis. GLILD again has near universal splenomegaly. Splenomegaly would be less common in our sarcoidosis population. And then this might require a little bit of a chart dive, but GLILD would be associated with hypogammaglobulinemia, whereas sarcoidosis is usually normal to somewhat elevated immunoglobulin levels. So just to compare and contrast, these are a couple of cases of comparing the nodules in GLILD to nodules in sarcoidosis. You can see that in GLILD we have a lot of ground glass, a lot of mixed ground glass and solid nodules, I should say. And sarcoidosis has a little more discrete peribronchovascular nodules. But I think what's helpful in these situations is also to go through the entire lungs. We see as we get into the lung bases, GLILD, the nodules are increasing, and sarcoidosis, there's relative sparing of the lung bases. So again, GLILD tends to be a basal predominant process, whereas sarcoidosis tends to be upper and mid lung predominant. So peribronchovascular nodules and consolidation. Talked about those in GLILD, but those are also words that we use for lymphoma, words that we can use with organizing pneumonia as well. GLILD tends to have a waxing and waning course of disease, whereas I really start thinking about lymphoma when I see progressive enlargement, where I see all the nodules or all the areas of consolidation progressively moving in getting larger. That does require reference to priors, it does require a couple of follow-up studies. But here are just some examples. This is a patient who had long-standing CVID and was followed for a number of years. And you can see that over time, GLILD really classically does this fluctuating, gets a little better, a little worse. You know, some of the nodules get better, some of the nodules get a little smaller, some of them get a little bigger. And so it really does do this sort of fluctuating behavior over time. You know, whereas lymphoma, I started really thinking about lymphoma when I see everything moving in the wrong direction, where all of the nodules are getting a little bigger, all of the nodules are getting more solid or more consolidative over time. And this is the example of the patient who had known CVID-related lung disease, but then developed a B-cell lymphoma on top of it. And then comparing and contrasting to organizing pneumonia, unfortunately, both of these are going to have somewhat waxing and waning migratory opacities, right? GLILD is really associated with a lot of lymphadenopathy and the splenomegaly, which, again, those soft tissue findings can help point you in one direction versus the other. So just to show some contrasting images of GLILD and organizing pneumonia, there's obviously a lot of overlap in terms of how these can appear. But one of the things that I also found was really helpful was just looking at the soft tissues here. And unfortunately, I didn't have a soft tissue window of the organizing pneumonia case, but comparing, obviously a very large spleen to a normal size spleen. So in summary, GLILD is a complex and it's a rare disease, right? There's a lot of overlap with other disease states. And so we as radiologists may not be able to come down completely hard on one diagnosis. We are part of a team that will be having this discussion. And ultimately, some of these patients will need to go to biopsy to get a diagnosis. But the things to remember for us is that GLILD is a basal predominant process. We see peribronchovascular nodules and consolidations. And on soft tissue windows, we really expect to see splenomegaly and lymphadenopathy, which will really point you in the direction of GLILD or potentially point you in another direction. All right, and then I just wanted to say one word on Kabuki syndrome, which is actually a very rare genetic syndrome that it's characterized by, it's characterized by very distinct facial features. It's also characterized by developmental delay. They can get some cardiovascular abnormalities as well. But what's interesting is that they get a CVID-like immunodeficiency. I'm not entirely sure how this whole constellation of findings comes together, but it actually is very well known that these patients with Kabuki syndrome, because of their CVID-like immunodeficiency, they are prone to both the infectious and the non-infectious features, similar to any other CVID population. So as an example, this is a 26-year-old man who was seen in our institution with a history of Kabuki syndrome, but actually had very classic findings of GLILD on his CT. So he was followed at our institution for his essentially CVID chronic lung disease. And again, just very classic imaging features of basal predominant ground glass, nodules, and septal thickening. Obviously has splenomegaly to go along with it as well. But a unique thing that if you see, be looking out for CVID. So in summary, CVID it's a heterogeneous group of disorders, right? These patients, because of their immunodeficiency, are prone to recurrent infections, but because of the immune dysregulation, also get a lot of autoimmune features. We as radiologists will be asked to evaluate them, not only for their chronic lung disease, but to be looking out for things like malignancy. GLILD is a form of interstitial lung disease. It's very unique to the immunodeficiency population, has a very strong correlation with CVID, but it's a hard diagnosis to make. There's a lot of overlap between GLILD and other forms of interstitial lung disease. So our familiarity with its patterns, with its appearance can be really helpful. I think that makes us really valuable in our multidisciplinary discussions. And even so, biopsy may still be necessary because there is a lot of overlap with their features. And the thing to remember always, lymphadenopathy and splenomegaly, those are the things to be looking out for, can help you really come down harder on the diagnosis or point you in another direction. With that, thank you for your attention.